I want to introduce Dr. Alain Labrique, who is joining us today as our guest speaker for our public health grand rounds. He will be speaking on global digital health, moving from shiny objects to national health systems strengthening. And he is with Johns Hopkins University Global Mobile Health Initiative. And it's our pleasure to have you here. I want to go ahead and turn it over to you and let everyone know that we are recording today, and we will stop for Q&A at about 10 minutes till 12. If you have questions, and you can put them in the chat, and I will be moderating the Q&A at the end of Dr. Labrique's talk. Thank you, and I'll turn it over to you.
Well, thank you so much, Camille, and thank you to all of you for hosting me today. It's a pleasure to be with you virtually. I wish we were under different circumstances, and someday soon we'll be able to do these grand rounds in person. But it's just a distinct pleasure to be here today, sharing some of the work that we've been doing for now over a decade in global digital health. And the work that I'll be presenting is really the work of a larger ecosystem of innovators and informaticians and public health practitioners who've been really looking at ways in which the technological revolution in which we exist can be leveraged to strengthen global health. And so without further ado, let me jump right in. I'm assuming you can see my screen. And I think it's useful to start with this dynamic map that shows what we like to call the mobile phone revolution, where from the early 2000s, we see the countries of the world inflating based on the proportionate volume of connections that those countries have seen in terms of mobile phone subscriptions. And this is happening, or this happened in the last decade or so, without really much input from the global health community. And what I think was really shocking to us as we were seeing this unfold, I was based at that time working in rural Bangladesh, trying to evaluate large-scale interventions to reduce maternal and neonatal mortality. We began to see this unfolding right around us as we were working in the rice fields of rural Bangladesh. And the stark realization that those patterns of mobile telephony exploding across the global south was mirroring the persistent and really to some extent intractable problem of maternal and neonatal mortality that we had been trying to solve. And so this is another similar map of the globe where the boundaries of the countries have been inflated based on the proportionate mortality among neonates and pregnant women and new moms experienced in those countries. So for us, it was really this epiphany to think about, is this a potential overlap between the digital health potential and the burden of disease and death that we were experiencing in the populations that we were working so closely with? And for me, it takes an added level of personal importance, because I was actually born in a small hospital after the War of Independence in Bangladesh. My mother almost dying of obstetric complications. And today, even though we've seen major inroads being made to these statistics, the number of neonatal and maternal deaths in South Asia and Sub-Saharan Africa continue to be intolerably high. This is what the landscape of Bangladesh looks like: green agrarian rice fields and interspersed with rivers and canals, very lush and green, but also a phenomenally challenged country when it comes to a lot of the indicators of survival and global health. It's in this country where in 1999, we developed a large-scale population research site working in close concert with the Ministry of Health and Family Welfare to study both the epidemiology of some of these nutritional and global health outcomes that were of interest to the Ministry of Health, but also to test interventions using a degree of rigor through randomized controlled trials to identify the efficacy of the interventions that were being tested, from nutritional interventions all the way through to health systems interventions and digital health interventions to improve the service delivery and outcomes. This is a population of about 650,000 people spanning about 600 villages across northwestern Bangladesh. So despite the major achievements that have been made since Bangladesh's independence in 1971, we still see under 5 mortality remaining high at about 30 per 1,000 live births. And what that means is today we have about 300 children dying each day. And that's really something that stimulates us to want to keep doing more to try and reduce that unacceptably high mortality. And you can see how the last 30, 40 years has really seen dramatic improvements, but nonetheless, this remains high. And these deaths and the morbidities that near misses and other severe outcomes experience are preventable. We have efficacious solutions, whether we're talking about skilled delivery or micronutrient supplementation. These solutions have to be delivered on time to mothers and newborns. WHO has many years ago published an anthology of interventions and antenatal care packages that can reduce both morbidities and mortality during that peripartum window when we know pregnant women are at greatest risk of severe outcomes. But we also are stymied by the community-based approaches, whether it's frontline health workers, community-based clinics, that just seem to be unable to reach that final mile to reduce mortality to the levels that we have here in the West. And part of this is the shortage of manpower, but I would also say a lot of compounded inefficiencies and delays that reduce the impact of these known efficacious interventions. So when we look simply at the burden of work that a single community health worker has to perform, we did a recent calculation. One of my master's students went out there and mapped out the entirety of data that one community health worker collects, as well as the service delivery burden that those health workers are responsible for, and came to the absurd calculation that each worker would have to perform about 200 hours of work per day in order just to meet the expected responsibilities for the month. So these inefficiencies and paperwork demands, they limit the health workers' ability to visit households and deliver care in person. It also means that there continue to be families, often those who need it the most, who are left out of the catchment of the primary healthcare system. Workers have complained to us that they have to carry multiple pounds of paper, registers, produce aggregated reports that take hours and hours each time. And already, I hope your minds are following me to the logical conclusion here, where there's surely more efficient ways of shifting some of these historical processes to more efficient systems, that even before we get to more sophisticated things like decision support tools and point of care diagnostics, process innovations can also make a significant improvement in the delivery of frontline care. From a supervisor's perspective, they are stymied to produce, to track field workers and to understand where the gaps in coverage are at a community level. This is an award-winning photograph of an Indian community health supervisor taken in 2012. And this is often the case where just the volume of paperwork is overwhelming. But it's not just a supply side problem. And I think this is where we have to take into account how families are engaged in the health system. When we talk about person-centered care and the engagement of the individual in the administration of care for themselves and their families, it's really important to understand how that's being achieved. A recent paper that one of my students did looking at the availability of emergency and basic obstetric care across this area where we have been working now for over 22 years, found that across 650 square kilometers, you can see here outlined in the blue dots, the only areas where facilities existed to provide comprehensive or basic emergency obstetric care. So that means an area about 4 times that of Washington, D.C. without any embedded basic or emergency comprehensive care for obstetrics in this large population of over 500,000 human beings. And so in the early 2000s, as we were working in this population, we began to document these really tragic experiences. Here we have the narrative of a young woman who's experiencing obstructed labor, describing the tragic journey that she went through during her pregnancy, where the 2 trained frontline workers who came to help deliver the baby at home found the baby with the cord wrapped around its neck, and they were unable to extract the newborn in time, leading it to its unfortunate death. In another instance, we just see that these harrowing experiences where postpartum hemorrhage, the woman began to experience severe bleeding. They take her to the government hospital where the attendants try to remove the placenta, but by that time, they were unable to push saline and get her rehydrated. And just before they were able to arrange transportation to a tertiary care facility, the woman has passed away. So these are the compounded delays and the frustrations that we just saw hundreds and hundreds of times happening over and over again. And we were really asking ourselves, are we seeing change occur either at the systemic level or at the individual level in these communities? And the answer was yes. We began to see, with the introduction in the mid-2010s in this typical rural Gangetic population, the introduction of satellite-based telephony, mobile telephony, piggybacking on the fiber optic networks that were created for the railways 20-some years prior, really begin to revolutionize the way people were experiencing care in this area. And from 2008 to 2010, we saw how rapidly this penetration of phone ownership in a very, very rural, previously disconnected part of the country was rapidly changing, with about 50% of households by 2010 reporting phone ownership. Quite a shocking transformation in a matter of just a few years from the introduction of the first wireless system in this community. And as we were studying the pathways to mortality and the experiences of these women, we began to see how in the near miss accounts and in some of the narratives that we were capturing on various pregnancy outcomes, people were citing the fact that they had used these phones to call for assistance, to mobilize resources, to ensure that they could get a skilled provider to the family during the time of the greatest need. And so we began to document whether mobile phones were being used during pregnancy crises. So these were about 600 near miss events. So women who said that they nearly died during their pregnancy experience. And you can see here that about half of them used a mobile phone during those crises. And this was back in 2007 to 2010. And for a diversity of uses, whether it was to call a provider or arrange transport or other types of resources during this crisis event. Now, we took the inspiration from what was happening in the wild to see, could we do a more structured intervention? Could we leverage the fact that families had access to phones across these rural populations to target and mobilize skilled care to be at the home when it was needed. And the long and short of that experience was, in this pilot study, we were able to deploy a skilled nurse midwife team to be there during or immediately after labor in about 90% of the births that were in this pilot study. So a really exciting intersection of a problem and a solution. But if I take a step back and ask ourselves, going back, and hopefully there's a few folks in the room with as much gray hair as I have, who will recognize where this ultimate inspiration comes from. When we go back to the 1960s and visionaries like Gene Roddenberry, who had come up with this show called Star Trek, in which the actors had access to phenomenal technology, like the one you see in the hand of Commander Spock here, a tricorder, which, back then in the 1960s was such a wild, far-fetched dream that a small piece of technology in the hands of a human being could allow you to look up information, to allow you to record audio and video, to communicate over long distances, and to capture things like vital signs or heart rates. And yet, I would dare say that every single one of you on this webinar today has access to this technology in your pocket. And so it's really redefined what we say when we speak about remote rural parts of the globe. Just before the pandemic began in 2019, I was in Kibwezi in Kenya, in a small village doing a vitamin A enhanced sweet potato project, and we were walking through these villages, and one of the things I noticed on some of these huts was numbers that had been etched into the actual clay. And as I was asking our local colleagues, is this a census number? Is this a malaria, coverage treatment number? Which is what I had seen in my experiences in Bangladesh. They said, of course not. This is the mobile phone, which to me was perplexing, given that there was no electricity, no cell phone towers, but they had come up with innovations to be able to receive those signals, leveraging the height of nearby hills or the tall trees that could be used to capture mobile phone signals at that time. But I began to really appreciate, as many of you have, how pervasive and really game-changing this penetration has been. Now, it's not all, you mustn't sugarcoat all of it, because there are still important digital divides and chasms of access, primarily by socioeconomic status and gender, that we need to pay attention to. But I think this is where we understand when we talk about global digital health, the opportunity and the problems really have intersected in a way that we around the world have sat up and taken notice of. And over the last decade, we've just seen a transformation in how those of us in the practice of global health cannot neglect the importance of mobile and digital health in how we deliver care and program interventions. Here is the working definition that the WHO and USAID together have convened a lot of experts from around the globe to come and try to distill what it is we mean by this new term, digital health, that has supplanted a lot of the other terminologies that we've used in the past to refer to this particular space. And over the last decade, we've really seen a transformation of the digital health space as the World Health Organization and other important normative bodies have really embraced this no longer as sort of a fringe of innovation, but really as a mainstream way of strengthening health systems. And it started really with the 2016 World Health Assembly resolution, followed by the 2019 digital health guidelines and classification schema for digital health, and a whole slew of other communities of practice, communities of scaling up global goods and investments for strengthening health systems, and of course, the 2020 publication of the Global Digital Health Strategy, which I'll speak a little bit about in just a moment. But this period of time, just since 2016, has really been a turning point for what we mean when we talk about digital health as a serious field of study and investment. So back in 2016, I was fortunate to be part of this group of folks from around the globe, representing every continent and many different disciplines, from informaticians to health systems programmers, posed with the question of, are we ready to begin to formulate guidelines for countries and implementing agencies around digital health strategies, much like we had for many other health systems problems and disease states, as you see here on the right. And this 4-year process culminated with the first ever guidelines that were launched in 2019 and still continue to be really seminal in country level investments in understanding where de-risked solutions exist for health system strengthening. Now, the 10 recommendations that emerged as part of this guidelines covers really the soup to nuts of the life cycle, starting with birth notification, moving through to targeted client communication, 2 types of telemedicine, stock and commodity tracking, training of health workers, decision support tools, tracking of populations and longitudinal provision of care, all the way through to death notification and civil registration. And so you can see here on the right the illustrative examples of types of recommendations, either blanket recommendations or conditional recommendations based on the strength of evidence and the quality of information available for that particular domain or problem. Now, we also did a review of the strength of evidence, and it was interesting because the quality of information available for rigorous digestion by a process like the WHO guidelines process, which many of you may be familiar with, really ended up munching through a lot of what was out there and putting it to the side as inadequate in terms of quality or thoroughness of documentation to be included in these very rigorous Cochrane reviews necessary as a precursor to the guidelines process. And so you can see here that for many of these guidelines, the level of effect was marginal and the certainty accompanying those effects were also marginal. But I think what came into play when considering whether a guideline recommendation should be made was not just the health outcomes, but also, as I began to allude to in the beginning, the potential for gains in program performance, that is to say efficiency or time, or reducing the cost of paper burdens by investing in some of these digital solutions. There were also a consideration of potential economic costs if frivolous digital solutions were invested in that could potentially both cause harm because of their poor construction, but also cause harm by diverting limited resources away from other public health programs. The other recommendations that emerged from these guidelines were the critical importance of building backbone systems, so national level infrastructures that would then enable the ability to develop and launch sustainable and scalable systems. So in plain language, as we move forward with the value proposition for countries, the things that we really were coming away with was articulating what the system hopes to accomplish versus how things are done currently. What is suboptimal about the status quo? Are there particular bottlenecks or pain points that are trying to be solved? How might things be improved using digital health innovations? That is to say, not reinventing the wheel, but also to plan and cost out carefully the implementation, the deployment, the training, and the monitoring and evaluation of these solutions at scale. And so a lot of lessons were learned as part of the digital health guidelines development, including what needs to be done to strengthen future guidelines processes that were undertaken for digital health systems. Now, even our articulation of what we mean when we talk about digital health has improved dramatically over the last decade. And going back to some of the work we did back in the early 2010s with this sort of 12 building blocks approach that has been cited an embarrassing number of times, but really served as the foundation for this much more rigorous and I think nuanced classification of digital health that WHO convened a wide group of folks from the International Telecommunications Union, the ISO group, and across the global networks of health informaticians to try and put together a shared language around the use cases of digital technologies for health. And this is available online, spanning these 4 bins of interventions that are client-focused, provider-focused, system or manager-focused, as well as data services. And I think it's a very, very elegant approach to enabling us to all be speaking about our technological solutions using a common terminology and a common language, enabling us to learn from one another's experiences in deploying these systems. But I think it also raised a really critical reminder to the community. And that was, even though we are talking about technology, innovations, and digital health, our eye should always be focused on the problem that we're trying to solve. And so as part of that broader taxonomy, there was also a taxonomy of health system challenges that were presented across these 8 different domains of health system constraints that we could begin with in our conversations with health systems managers to say, let us first focus on the problem you're trying to solve, and then move to the library of possible solutions for that particular problem. Now, as you know, we're all here in an academic environment and thinking about the role of academia in this growing ecosystem, I think it's critical to appreciate the many ways in which academia has and can continue to move this field forward. And as I mentioned a moment ago, strengthening the rigor with which programs are monitored and evaluated is key, because that feeds into the future guidelines of around digital health and the confidence with which countries can invest in digital health solutions. I think developing better and more sophisticated frameworks that reflect the ever-changing landscape of technologies, guiding, as Camille and I were just speaking a moment ago, guiding the ethical and social and legal dimensions of deploying digital health solutions in some of these contexts. And also, I think leveraging the informatics processes of how to properly engage with the end user and build systems that are responsive to problems and expectations of those end users in the context that they are working. One of the things that we tried to do several years ago was develop a series of criteria for those of us working in digital health, and this was commissioned by the World Health Organization, to build an mHealth evidence reporting and assessment checklist, where we would ensure that manuscripts that were published using this checklist could actually pass the gristmill that the Cochrane reviewers were hoping for when looking through the body of evidence around particular use cases for digital health. We also tried to develop, using this guide, the Monitoring and Evaluating Digital Health Interventions, a more sophisticated set of frameworks that helped address the quandary of fitting evaluation and monitoring solutions or approaches to the level of maturity and to the claims that were being made by the digital intervention programs. So making sure that the test is appropriate to the intervention, right? So not asking, not examining a fish on its ability to ride a bicycle, but a fish on its ability to swim, to speak a little proverbially. Now shifting tracks a little bit, I wanted to talk about not just the role of academia, but also the role of WHO as a normative agency in really helping to shape the direction of digital health as a field. And so I mentioned earlier the various World Health Assembly resolutions that countries or member states began to sign on to as really calls to WHO to take this seriously and to provide the kind of normative guidance that countries look to WHO to help them understand where their investments need to be made in digital health solutions. At a time when ministers of health were being overwhelmed by vendors and private solution providers clamoring at their door for investments in this space. So as a result, in 2019, WHO actually launched a new structure and a new department under the chief scientist, Soumya Swaminathan, where there was a Department of Digital Health and Innovation focused really on identifying pathways and supporting member states in digital health. This led to the Global Digital Health Strategy that was launched in 2019, but taking effect in 2020, with 4 key strategic objectives. These objectives are here on the slide. I'm not going to read them in great detail, but really they at a high level, the objectives are to develop a global collaboration and knowledge transfer and facilitate learnings across WHO regions, to support countries in the development of a digital roadmap or strategy so that investments follow a strategic path and not the sort of Wild West approach that characterized the early 2000s. Investing in and mapping out the needs for digital health governance that will help these systems be sustainable and scalable, but also understanding the approaches necessary to build human-centered health systems by ensuring things like gender and human-centered design being at the core of these solutions that are being developed. And many of us who were part of the last technology revolution with e-health, we know sort of how the graveyard of e-health innovations is really littered with great intentions, but many of which did not reach the level of scale and sustainability that we would have hoped for in the 1990s. Another really useful tool that really tried to distill the universe of guidelines and guidance from WHO and from other normative agencies was this digital implementation and investment guide that came out just last year or 2020 actually, that walks member states or ministries of health through a very systematic process of developing that digital health, costed digital health plan that's part of the strategic objectives of the WHO global strategy. And so it starts with, and those of you who are informaticians in the audience or who have studied informatics will recognize this process as defining the current state, understanding the enabling environment, defining the future state, planning that enterprise architecture, and then once the problem and the opportunity are clearly mapped, then formulating the library of digital health solutions required to then scale up and sustain. And so it's a really well-crafted piece of work that was led by PATH and a few other groups in working with WHO, and this is also available online. Just to give you some illustrations from this document, here's some of the various worksheets walking through both a series of business process mapping across the health system, creating workflows that help describe the current state and enable us to move from the current state to the future state, thinking about both the ecosystem at the top, the interoperability components required, as well as the granular digital health applications at the grassroots level needed by the health systems. And so here's the current state, here's the future state, and hopefully mapping from one to the other, the potential digital applications that can be used to strengthen the health systems. But it also touches on the human-centered design processes. And so thinking about the personas involved as stakeholders in this process, the cost categories that will drive the budgeting around these technological investments at a country level. And so all of these are then brought together as an overarching summary that not only talks about the actors, the priorities, the context, but also the cost of these large-scale projects at a country level. And of course, it also touches on the importance of the sustainability elements from policy to technical to institutional and financial required for really that long-term vision that's needed for this level of sustainability. Now, the other thing that really has changed over the last decade, and it has been sort of a mainstay of strengthening this ecosystem, and that is communities of practice. The number of large consortia, whether we're talking about the Global Digital Health Network or the Asian Health Informatics Network, the annual Global Digital Health Forum, and a slew of other similar, there's an African digital health network that has now been formed and is very active. They're launching their first Pan-African Digital Health Forum in the coming week. And so these communities of practice are really vital to help build that capacity to learn from each other's successes and failures. And I think that that's really critical as we go forward, not just to talk about all of the great things that have accomplished what we hoped they would, but also to make sure we talk about things that don't work and why those things have failed so that we can mitigate those going forward. There are tools, and I would really strongly encourage all of you in the audience today who are working on a global context to either add to these tools or reference them as you are building your various intervention packages. This is the Global Digital Health Index, a tool that has been working with groups from around the globe to build a multi-dimensional assessment of the readiness of countries for digital health interventions and sustainability. That's growing on this was a screenshot I took some months ago, but it's much more heavily resourced now than it was back then. This same group also puts out an annual State of Digital Health report that is actually very, very insightful when you want to understand the state of funding and investment in sort of the national scale infrastructure required for digital health to succeed at the level that we're discussing. You can see here the various dimensions, the 7 dimensions against which maturity is measured, and it is constantly refactored based on new developments at a country level to, again, situate where a country might be on a global context. And you can see here that one of the continuous pain points in maturity remains this workforce capacity. And so one of the key investment areas WHO is looking into is really this whole competency-based training at all levels of the health system to ensure that we have a digitally capable and skilled workforce in the health system. The other sort of, I will say, frustration that I've experienced over these many years is wheel reinvention. And I'm sure I share that with many of you who have seen the same solution being deployed time and time again in country and then the neighboring country, where there are missed opportunities for cross-pollination and leveraging experiences of other geographies. And so the Digital Health Atlas is actually hosted at WHO, and serves as a clearinghouse for solutions at a country level to be uploaded and described using those elegant taxonomies that we talked about earlier, so that we can start to search on problem domains or types of solutions that may exist either globally or regionally in digital health. So I strongly recommend you visit these sites and contribute to them, because I think that only helps to strengthen the value of these tools. So in the last few minutes that I have, I just wanted to maybe speak a little bit about the next frontiers and where we are heading as a global digital health field. And one of the I think key areas that I wanted to share with you today is this concept of smart guidelines. And I think it's really a bold move on the part of WHO, as they have thought about how do we move from our current state of guidelines and recommendations that we make to countries about best practices from the treatment of HIV and malaria all the way through to antenatal care components. How do we go from these large books that we print and that sit on shelves in ministries of health to where digital health systems that are increasingly in the hands of frontline workers, of providers, of EHRs that are being deployed at tertiary care facilities? How do we move from these static paper-based guidelines to a state where WHO, after its very, very extensive process of developing consensus and then deploying guidelines, that those guidelines can be not just digitally structured, but machine readable, as you see here in the L3 or level 3 of sophistication, even to the point where they might be executable. So you might just download the core application from WHO and then modify or build upon it, as opposed to refactoring something de novo. One of my students just got back from Kyrgyzstan last week, where they had spent somewhere upwards of 90 hours with clinicians and local experts to translate the guidelines into locally adaptable decision support algorithms, something that should not have to happen in 144 countries around the world. And then the last and most ambitious stage is really this L5, which is, as many of us are familiar with, this dream of precision health, where we're talking about dynamic machine learning based algorithms that refine themselves to the context and the population where those algorithms are being deployed. You can see here that there's a lot of work that's been done around the globe to build on these smart guidelines. This is the clinical logic that was published a few months ago around antenatal care. And so it's sort of taking those paper guidelines and translating them into these swim lane workflows, developing clear rules that can be interpreted into machine readable language, creating data dictionaries and semantic and syntactic libraries that can be used to help harmonize how this data is stored. Amazing future dream that we would be able to have, transnational health records that could port seamlessly as individuals travel or migrate with their health record following them in these secure cloud-based solutions. WHO has released reference apps to help inspire countries that are built on these backbone guidelines to help facilitate antenatal care delivery in countries around the globe. And really, as on that note of AI and machine learning, I think this really is a new frontier, and not just it was at its initial stages a buzzword that a lot of people were talking about but really not doing. But as we see the potential of these sophisticated algorithms to identify connections, to monitor automatically massive data streams and identify areas of need at a health systems level, I think that there's a really exciting potential set of use cases. And the USAID and Rockefeller recently published a really elegant report that created this framework you see here on the right, articulating and elaborating on some of these different dimensions. I think we do have to continue to challenge ourselves to think about person-centered care, and really how can technology move us away from this paradigm of the hospital as the center of the care paradigm. And as many other sectors have done, as education and banking and finance have all moved towards solutions that work around the person and the convenience of the individual, realizing that that's the business model that works best. How can we do this for health and healthcare? And I think there's a lot of innovation that you in the audience have been working on, that over the coming decade will be transformative to health system performance. And then, of course, we have the tsunami of NCDs, and as we emerge out of the urgency of the COVID-19 pandemic, understanding that we really have to prioritize the use of these innovations to improve our responsiveness to non-communicable diseases. That's really the major killer of humans prematurely around the globe. How can we leverage technology to enable individuals to strengthen all of these various facets, whether it's incentives for modifying behavior, facilitating food choice, helping with smoking cessation? We have to leverage all the tools we have to curtail this major onslaught of preventable mortality. So over the last 2 decades, this really has been a phenomenal space to be a part of and to just watch emerge. This diagram on the left may be familiar to some of you. It's a famous M Health staple picture that represents the state of M Health in Uganda in 2010, before the Minister of Health issued a moratorium on any new digital health interventions, until all of these programs were registered and began speaking to one another, as opposed to this state of what was called pilotitis that was afflicting this country of Uganda. And we're seeing country after country now, as WHO and other agencies and ministries of health move towards more enterprise thinking and really large-scale national architecture. We're seeing these sorts of, and this is a diagram on the right of open health information exchange with an interoperability layer and the various shared components that digital health innovators can tap into, all the way through to point of care applications that speak to each other without having to reinvent the wheel. I would encourage you all to look at Digital Square, or if you're not already part of it or working closely with Digital Square. It's a phenomenal initiative that's led by PATH and other actors in the field, looking at really developing building blocks and global goods that can assist countries around the world to speed up their pathway into digital health and scale. And at present, there are about 27 of these global goods that have been vetted and accepted into the library. And they're moving into also providing capacity development and country level support, as well as supporting some of those networks or communities of practice that I spoke about a few moments ago. And then very lastly, as we are not fully out of the woods with the COVID pandemic, I think there's a lot for us to learn from ways in which technology and digital health did strengthen and enable our fight against this pathogen. But I think we fell short in many ways. And I think it really behooves us to take a step back and understand the things that worked, and also try and untangle the things that did not work in terms of technology for pandemic mitigation. And I think only by learning from these things that we will truly do justice to the many lives that were lost as part of this pandemic. There was a report we put out a few months ago through the Global M Health Initiative here at Hopkins, and I'll place the link in the chat for folks who want to see the way in which we did this assessment and learn more about some of these platforms. And the process might be helpful for those of you looking at similar evaluations of technologies. There's been a lot of great work. Joby Budd at University College London wrote a really elegant article looking at digital health technologies for COVID-19 that I recommend highly for anyone interested in understanding these technologies. And I think, I'll just leave you with this last favorite framework of mine, and that's the Gartner hype cycle, where the Gartner group every year publishes this hype cycle looking at all types of technologies. And, it starts with innovation triggers, which skyrocket to a peak of inflated expectations, but often find themselves barreling down into this trough of disillusionment before adequate evidence and adequate confidence is built to move those solutions into enlightenment and productivity. And so I guess my final call to all of you is to really think about how do we move valuable technologies and valuable innovations from languishing in the trough of disillusionment to enlightenment and productivity. And with that, I look forward to the brief time we have to have some questions, but also to reach out to me to discuss, what is M possible and how we can work together going forward. Thanks so much, and back to you, Camille.
Thank you. My goodness, the resources that you presented are really incredible. And please put your questions into the chat so that we can try to get through some of them. But one of the things that's jumping out at me is the amount of resources and work that has gone into developing those resources is the implementation and dissemination and getting the information out to where they can be adopted and used. And so it seems that dissemination and implementation science is a really critical piece of what is in the mix of this. And I'm curious about how that is being built into the infrastructure.
And it's a very, very important point. And I think, as our implementation science sophistication grows, as these national level programs begin to take hold, we're starting to see a lot more careful implementation science being done. And some great examples actually come out of South Africa, which has some of the first national scale digital interventions, as well as India, which have now had these either state level or national level deployments going for several years. And so they're at a position to take a step back, understand the components that have been working, understand where there's been, voltage drop over the years, and to try and really examine the factors that play a key role in sustaining these technology inputs into the system after the initial enthusiasm maybe has waned. But I think one of the key issues there is really it requires a sea change in how we think about digital health investments as infrastructure. Right, so we have to move beyond the $50,000, $100,000 pilot innovation grants, where you know we're really, and there are conversations happening as we speak about shifting to you know, a global fund for innovation and technology, where national scale investments can be made in the type of architecture required for 50 million users as opposed to 100,000 users or even 10,000 users, right? So architecturally, we're talking about different animals. We're talking about the funding and planning that's required for the human resources to train people pre-service, in service, the continued investment in upgrading technology. And you know, it's not just a one-time purchase of 100,000 tablets or units that are in people's hands, but every 3 years those depreciate and have to be replaced. And so you're talking about continuing cost. And then there's the underbelly that none of us sort of likes to talk about, but it's the ecological impact of e-waste. And where are all these devices and technologies ending up once they go through the hands of health workers? So these are all great dimensions that really need to be thought through carefully.
It's a very complex ecosystem. I really love how you presented that. Dr. Anderson.
Yeah, similarly, thank you so much, Alan. That was a brilliant talk. Talking about the underbelly of sorts, I was thinking as you were talking about not just the scientific D&I components of this, but the security element. How are you thinking about security, privacy, you know, stability as we move forward these mHealth initiatives?
Yeah, no, that's a fantastic question, and one of the core pillars of many of these conversations that are happening at the global level, as we examine where digital health worked and did not work as a key approach to COVID-19 mitigation. I think we have a lot to learn from countries that had very robust governance frameworks around privacy, around data security, and also around standards, where there were pre-existing robust standards for interoperability that allowed countries to stand up solutions in a very, very short time frame without going through, you know, what is usually a 5-year process of rigorously examining the 150 standards to choose from and then selecting one. But you know, countries that had, for example, been through the SARS epidemic a decade ago had already, for the large part, thought through and had in place some of the governance and legislation required. You know, Hong Kong, New Zealand, Australia had very, very strong legal frameworks on the books to fast track some of the deployment of the Singapore, as another example, to fast track some of these solutions when they were urgently needed. So you've hit the nail on the head, and I think that it's not that we're working in a vacuum. There are so many great examples that each country doesn't have to sort of wrestle with this problem de novo. I think that and this is why those communities of practice are really, really phenomenal. There's, of course, a scale of comfort, of individualistic to collectivist societies that have to be considered, and what are the elements of data sharing or of potentially of privacy that a particular country or culture is willing to sacrifice for the common good. And that's a conversation, unfortunately, that can't be regulated at a global level. It has to be a country by country set of decisions.
Well, trust is at the core of that foundation. And I think that if we build in the time it takes to develop that trust, and as you said, the funding and support for the infrastructure development needs to be adequately funded for these things to happen.
I think, Camille, the example of Taiwan
Mhm.
is actually phenomenal, and one that it will be tough to replicate, but their digital revolution of complete transparency. I mean, just an obscene amount of transparency in terms of like just relegating some of these technology infrastructure developments over to, you know, white hat hackers and you know, an informatics community of developers, to try and break each other's software and create a public good that would be useful at a country level, is really worth Audrey Tan, I think, is the name of the leader there who helped to initiate these. But
well, thank you again so much for being a part of our conversation today. I really look forward to hopefully staying in touch with you as you transition to your new position. And thank you again for being part of our Grand Rounds today.
It was my real pleasure, and you know, thanks so much for having me. And I know many of you have to go on to the faculty meeting, but I'll just put that link in the chat so folks can have it if they would like.
Thank you so much. We really appreciate your time and
Have a good
resources.
afternoon and great weekend, everyone.
Thank you. Take care.